at the University of Nottingham, and she's going to talk about using NRT for smoking reduction in pregnancy. Thank you, Sophie.
Thank you. I'm going to share my slide now.
Oh, Sophie, may I just interrupt you for 2 seconds? Forgive me. I'm supposed to tell everybody, can you put any questions you have for Sophie in the chat? Thank you. Sorry.
Okay. There we go. So everyone should be able to see my slides now. So yes, thank you for the introduction. So yes, my name's Sophie and I'm based at the University of Nottingham. And the project that I'm going to be talking about today is looking at using NRT or nicotine replacement therapy for smoking reduction in pregnancy. So to give you a little bit of background to this project, smoking during pregnancy is a major public health issue, contributing to miscarriage, stillbirth, preterm birth, low birth weight and sudden infant death. And in the UK, 23.3% of women smoke at some point during pregnancy. And this exposes over 160,000 fetuses each year. So NHS guidelines promote complete abstinence, stating that there is no safe level of smoking. However, through my research, I've seen that there are huge challenges to quitting smoking during pregnancy. So research shows that many women struggle to quit abruptly and around 45% don't make a quit attempt. And even in cessation trials, only around 5% remain smoke-free by the end of pregnancy. So for those who struggle to quit or relapse, there is no alternative form of support currently available that isn't cessation focused. So this led me to wonder whether a more gradual approach, so for example, by reducing smoking, might help women make lasting behaviour changes. And smoking reduction is an approach that is actually recommended for non-pregnant individuals struggling to quit. So nicotine replacement therapy, or NRT, helps to reduce cravings and is recommended by NICE for most non-pregnant smokers who can't quit outright to help them reduce their smoking. And this is because using NRT to reduce smoking can also result in successful quit attempts. So this group are around 87% more likely to stop smoking even if they didn't plan to quit. So while NRT is recommended during pregnancy for cessation, its use for smoking reduction is not advised due to safety concerns. So for example, in case it leads to higher nicotine intake than when smoking alone. So because of these safety concerns, there has been limited research on the effectiveness and safety of using NRT to reduce smoking during pregnancy, as most studies have focused on smoking cessation. So to address this gap, we applied for funding from the SPCR's F1 funding round. And our funding supported 2 studies. So the first study focused on analysing existing data from 2 cohort studies, which were part of a larger programme of work called the NREADY study. So NREADY was a study developing a package of support to help pregnant women use nicotine replacement therapy more effectively. And as part of the study, we collected detailed daily data through a smartphone app called NICUse, which tracked women's smoking habits and NRT use. And our goal was to understand how the amount of nicotine delivered through NRT influenced smoking behaviour during pregnancy. And specifically, we wanted to explore how changes in nicotine dosage might affect the number of cigarettes smoked per day. So although the sample size was small, just 24 participants, we gathered rich longitudinal data. So this included baseline information, as well as repeated daily measures of cigarette use and NRT consumption, giving us valuable insights into how these patterns evolved over time. So let me share some of the key findings from this study. So first of all, 70% of participants who were using NRT to quit smoking actually smoked and used NRT on the same day. And then secondly, we observed an interesting pattern. So As the daily nicotine dose from NRT increased, the number of cigarettes smoked decreased. And our modelling provides a little bit more detail. So for every 10 milligram increase in daily NRT dose, participants smoked 0.6 fewer cigarettes per day. So that was a reduction of around 24% in cigarette consumption. And to put that into context, someone using 4 to 5 pieces of nicotine gum per day could reduce their smoking by about 40%. So then, building on these findings, our second study explored a related question: how acceptable is it to use nicotine replacement therapy to help pregnant women reduce smoking rather than quit entirely? So our second study was a qualitative study designed to delve into the motivations and barriers women face when using NRT in this way. So to gather these insights, we conducted semi-structured telephone interviews with 18 pregnant women from across the UK, all of whom were either currently smoking or had recently quit. And by focusing on their experiences, we aimed to better understand how NRT might be used as a harm reduction tool during pregnancy and what factors influence its success. So the key findings from our second study were, first of all, half of the women that we interviewed had used NRT to reduce smoking during pregnancy, and many of them strongly supported the idea that the NHS should recognise smoking reduction with NRT as a valid option. And then secondly, two significant barriers stood out. So the cost of NRT products and the stigma around using NRT while pregnant. And these were key factors that limited its use. The women also highlighted the importance of offering NRT for reduction early in pregnancy, paired with tailored and structured support to help them use it effectively. So we concluded that using NRT to reduce smoking rather than focusing solely on quitting could be an acceptable and supportive strategy for pregnant women, especially when backed by the right guidance and resources. So I'm pleased to share that both of these studies have been published open access, the first in Nicotine and Tobacco Research and the second in BMJ Open. And we've also secured additional funding as a result of this work. So I've been awarded the Griffith Edwards Academic Fellowship from the Society for the Study of Addiction. And this fellowship will enable me to take this work further by leading a programme focused on supporting pregnant women who can't quit smoking entirely. And the aim is to develop strategies that use nicotine replacement therapy to help women reduce smoking and maintain those reductions until childbirth. And to support this next phase, overall, we've secured over £587,000 in funding, including an additional SPCR grant and 2 NIHR programme development grants. And these funds will allow us to build on the insights gained from the SPCR funded project and expand the scope of our research. So this next stage, I think, represents an exciting opportunity to refine and develop practical harm reduction approaches that can make a real difference for pregnant women and their families. But what I think is really exciting about this programme of work is its potential impact. So if this novel approach to smoking in pregnancy proves successful, it could radically change clinical practice, saving the lives of unborn babies and improving the health of both women and infants. And the findings could help over 70,000 pregnant women in the UK each year who are unable to quit smoking and are not currently eligible for alternative NHS support that isn't focused on cessation. And ultimately, if pregnant women respond similarly to non-pregnant individuals when using NRT to reduce smoking, my research could lead to many more women successfully quitting smoking altogether. And I'd just like to take a moment to express my thanks to the SPCR for their continued support, which has been really pivotal in advancing my research career. So their funding has supported me at every stage from my PhD to a postdoctoral fellowship, as well as through seed corn and bridging funding. And this support has been instrumental in helping me build this body of work and drive forward research that I hope will make a meaningful impact. So thank you very much for listening today. Let me stop sharing my screen.
Thank you very much, Sophie. I'd just like to say how fantastic your presentation is. I mean, not only really important work, but work that's led you to get a fellowship. So and you've actually met the two criteria for the School for Primary Care Research: developing research capacity, developing you, and doing really good research underpinning practice of primary care. So I found really exciting. I've got some questions for you, but let's see what's in the chat.
Hi, we've got a question from Hallie. Hi, Sophie, great presentation. I know you had some excellent public involvement in this project. Do you mind sharing a bit more about how you involved people across the project and how you think their involvement contributed to the impacts coming out of the project?
Absolutely. We've got some really kind of dedicated public involvement members that we work with, and they've worked with us for a number of years. They're all women who have personal experience of smoking in pregnancy. And they really do help us with our research, and we involve them as co-applicants as often as we can. And we approach them when we're kind of developing new research ideas. So they really kind of help focus what questions are important for our population and provide feedback on kind of the research that we're planning and all of our materials, particularly kind of participant-facing materials. But they're also involved in some of the elements of dissemination as well, and helping us to kind of decide what the important messages are and where we can disseminate our findings so that they reach the people that we want them to reach.
Thank you. Sophie, can I ask a question, please?
Absolutely.
I've got three questions. But I'll let other people come in as well. First of all, I was fascinated by the NICU's app that you used, and could you tell me a little bit more about that?
Absolutely, yeah. It was developed by one of the members of our team, UA, and it's developed for use with some of the trials that we have ongoing within our research team, SNAP2 and SNAP3. And it's an app that women can log into daily and record how many cigarettes they've smoked and what NRT they've used and in what doses. And it provides really valuable ecological momentary assessment data, so we can really track that behaviour on a day-to-day basis. And the UA has done a fantastic job with the app. It's so well designed that our participants fill it in with great regularity, and they log in every day and they're able to record that information. So it's a really valuable data collection tool, and we're very lucky to have UA in our team with her app development skills.
I was just wondering, if somebody sort of has a cigarette, can they do it in live time and sort of just note it?
So yeah, so I think they go onto the app once a day, and they can record what they have smoked that day, which obviously helps a lot with recall bias as well, because ordinarily in research we would be collecting that kind of information probably on a weekly basis, and so recall bias is a huge problem for what they did earlier in the week. So yeah, we ask them to go on daily and record that information, and it really does help with collecting accurate kind of day-to-day information.
Okay, thanks. Now, the next thing I was intrigued by, where you're saying there was a stigma around using nicotine replacement therapy whilst pregnant, but these are people who are smoking, and I thought that's more stigmatizing. So can you unpack that a bit?
Yeah, this was an example from the qualitative study that we conducted, and we had one of our participants in particular who felt very embarrassed going into Boots, for example, and buying nicotine replacement therapy whilst visibly pregnant. And anecdotally, we had some other ladies say that they would be embarrassed to be kind of seen with the nicotine patches perhaps visible on their arms when pregnant. So there was really a preference for using more discreet versions of nicotine replacement therapy. So, for example, the gum that could just be any normal chewing gum. So I think that stigma that surrounds smoking in pregnancy or needing kind of aids to help them stop smoking in pregnancy is really real for the pregnant women that we work with.
Great, that's really, I suppose if you're smoking, you can go and have a cigarette, but you can't hide going to buy the patches, I guess.
Yeah.
Thank you. Can I ask, Kirsty's got some questions in the chat. Do you want to read them out, Jess?
Yeah, I'll read out Kirsty's question, which is, are there any plans to do a larger scale study? And was any additional intersectionality looked at, i.e. socioeconomic, education, etc.? And there's another part to that. Also, I wondered if there were the findings in terms of behavioural change and recommendations for this.
Yeah, so this is some of the work that I'm doing at the moment. So we are one of the NIHR programme development grants that I'm involved in at the moment is replicating our analysis, but in a much larger data set. So we've got, I think it's over 500 participants that we've got similar daily data for smoking and nicotine use. And so we're kind of replicating this analysis in a much larger data set, and that will enable us to look at some of the kind of confounding factors that may influence this relationship between daily NRT use and cigarettes per day, including socioeconomic factors, education, age, and some of those other issues that we know are related to smoking behaviour in general population and in pregnant populations as well. And then for the second part of the question, looking at behavioural change, again, so part of my fellowship that I'm now working on is developing an intervention to use nicotine replacement therapy to help women reduce their smoking and maintain those reductions until childbirth. And so we're looking at behaviour change techniques that may be effective in that intervention and how we can develop an intervention that we can hopefully take forward to test in feasibility and pilot work.
Thank you very much, Sophie. Well, we've had our good, generous 5 minutes for questions. So thanks for a fantastic presentation, a super start. And I'm going to now move on to ask our next speaker. Well, actually, it's a double act. Sharon Dixon, who's a GP and NIHR doctoral fellow, and Abi McNiven, who's a senior qualitative researcher, a medical sociologist. And they're coming from the Nuffield Department of Primary Care at Oxford. And they're going to talk to us about developing understandings of supporting endometriosis in and for primary care. Thank you, Sharon and Abi.
Hello, so I'm Sharon Dixon. As I said, I'm a GP and doing an NIHR fellowship, and I'm really excited to be here with Abi. Our grant really started our ongoing research journeys for both of us. Abi?
Thank you very much. I'm a qualitative researcher, Abi, based in the Nuffield Department of Primary Care Health Sciences, and we're presenting today on, can I just check everyone can see my slides? Sorry, just because I can't see it up on the screen. Is it visible?
Yeah,
I can see the slides.
Okay, brilliant. Thank you. Fantastic. So we're presenting today on developing understandings of supporting endometriosis in and for primary care, our SPCR story.
So endometriosis is a condition where tissue similar to wound lining tissue is found outside the uterus, and it is believed to affect an estimated 10% of women or people female at birth. And it can cause a huge spectrum of symptoms. It can range from not causing any obviously aligned or understood to be aligned or kind of related symptoms, but to be associated with menstrual pain, heavy menstrual bleeding, long-term pelvic pain. It can impact for some people on fertility, and it has quite significant and well-documented impacts on well-being, on quality of life. One of the things that is really clear in endometriosis is that many people experience really complex and difficult journeys to receiving a diagnosis and then accessing kind of evidence-based care for their endometriosis. And there are quite well documented time delays between presenting to primary care or to GPs with symptoms and ultimately receiving a diagnosis. And much of that work has been done using primary care databases, and the kind of understanding or framework to make sense of that had often been kind of based around lack of GP awareness, or that GPs aren't considering or thinking about endometriosis as a possibility, which is clearly a very important consideration. But I think we wondered whether it might be a bit more complicated than that. And James Lind Alliance recognised that what we didn't know was how to improve those care journeys. And as primary care and GPs are kind of the first port of call for many people who will be presenting symptoms, and that's very well documented, we thought that understanding how GPs approached this kind of clinical presentation and what their considerations were and how they might approach it would be a really critical way to try and understand resonant and relevant and meaningful ways to improve those care journeys. So our first SPCR grant allowed us to do exactly that. We spoke to 42 GPs around England, supported by the CRN, and we spoke to them about and we gave them a clinical vignette, a fictional vignette. So rather than starting with the diagnosis, we gave a case of how somebody could commonly, or a sort of textbook presentation where somebody could have endometriosis as one of the possible explanations for the symptoms they were experiencing. And we worked through a vignette with them. And the idea for that was to make it a very transparent space where we could kind of explore and reflect on their think aloud kind of considerations about what they thought about, how they might approach it, what tests they might do, when they might start talking about it, and how they would navigate that with the person in the room. And what that showed is that, perhaps not surprisingly, because this is what we were looking to explore, is that although, of course, awareness, consideration of the likelihood or the possibility of endometriosis is a critical kind of prerequisite to underpin those steps, that there was a huge amount of other complexity. GPs were able to contextualise their considerations in the real-world context in which they were working, about services and constraints. It also unearthed some real areas of concern for GP or uncertainty, some of which were embedded in guidance but made it very difficult for them to refer. And a really important example of this is that national guidance suggests a trial of kind of first-line treatment for symptoms and referral on if these aren't acceptable, tolerated or effective. And GPs were left really, really concerned about what best care looked like, or how they should hold care if they understood that symptoms had been alleviated by the first-line treatment that they offered. And that's really important, because the first-line treatment for symptoms like menstrual pain is often the first-line treatment for endometriosis, so some people might get better. We also really wanted to make sure that our work spoke to people with lived experience of endometriosis. So we took our GP findings to 10 people with lived experience to ask them how they made sense of what we'd heard from GPs, how they thought we should use them, and how they thought we could use what GPs were thinking as meaningful ways for GPs to try and improve care. And we were able to publish those tips within our paper.
In 2021, the government held a call for evidence consultation asking about women's health in England with the intention of developing a strategy. They received over 400 responses from professionals and others working in areas like healthcare sectors, in addition to nearly 100,000 responses from women across England. And as part of that submission, we submitted our possible endometriosis diagnosis paper. And this was referenced in the Women's Health Strategy when it was published a year later in 2022, highlighting our study and the intention to use the findings to inform understandings of barriers to diagnosing endometriosis going forwards. In addition, our paper and the approach that we took with the study was picked up and recognised as potentially useful for thinking about more broadly women's health and other areas of reproductive and gynecological symptoms. And again, in the strategy, it was highlighted as this being an area where there was a recognition there wasn't a lot of evidence and literature at the moment. And we were invited to extend our study approach to think more broadly about women's health, which is what we did in the WEAVE study. And in this study, we interviewed 46 primary care practitioners, which was mainly GPs, but also included nurses and others such as clinical pharmacists. And we interviewed them in 2022 and were asking quite broadly about different areas of women's health, but also quite focusedly sort of thinking about minority and marginalised experiences and how primary care in particular for women's health topics is grappling with the needs and challenges. So we published this paper in the BJGP and have also presented it at RCGP and SAPC in 2023 and won Best Poster Award at the RCGP conference in 2023. And as this diagram from the paper highlights, our findings really sort of resonate with the way that complexity, relationships and advocacy is seen as absolutely core to women's healthcare in primary care, with 3 key areas of being alongside a person from cradle to grave, maintaining a balance within and across primary care between general and specialist skills, and the necessity that relationships work best between generalists and specialists when it's reciprocal, and that in combination they make more than the sum of their parts. However, we also heard from our participants that there were really difficult challenges that they were navigating to be able to uphold this core of primary care for women's health. And that included the challenges of striving for equity in a collapsing system. The gaps and the concerns that they have were something they were very acutely aware of and working very hard to work towards improving the health of women everywhere, but also recognising that they were firefighting with limited resources, and that so frequently the GP continues to be cast as the villain in media and in other sectors as well. In addition to this overview paper, we've also published a paper in BJGP on perimenopause help seeking and ethnic minority communities, which has been well received again and received recognition for the paper in the journal. And we've more recently published a paper unpacking trauma in women's health in primary care as well.
That original SPCR grant and work that we did continues to absolutely underpin the ongoing work that we've been able to do. So when we looked at the kind of uncertainty that GPs were holding about what best care looks like when you're supporting people with symptoms in primary care, young people, so adolescents and teenagers, perhaps really exemplified that group where they were desperately concerned, and where the GPs that we spoke to in that original study were concerned about and raised their desire for better resources and their concern about the kind of lack of tailored resource and evidence to guide them in that space. So that question has very much underpinned my doctoral fellowship application, which I was lucky enough I'm ongoing doing work with now, which has included both observational epidemiology, trying to understand the work that is happening in general practice, and also a large qualitative study with which we're going to make patient-facing resource, but also educational resources for primary care and for young people, but told in their voices and with their messages. And we've also published an evidence review and a clinical guide about adolescent period pain for GPs in the British Journal of General Practice. Abi and I, with other amazing collaborators, have also been part of a team who've got an HSDR grant to understand endometriosis experiences, and again to extend and expand the work that we started with our SPCR grant. So endometriosis journeys, as I've said, are often complex, but there are inequities or further complexities within that. Much of the work, previously much of the qualitative work, represents people in very specialist centres. So they've recruited from very specialist centres or have recruited from support and advocacy groups. And there's increasing recognition that there are other experiences of endometriosis. And as we strive to improve care, it's really critically important to hear all of those. So this study is around recruitment from primary care, from people within general practice, and trying to really seek a broad range of experiences. There are well-documented inequities by socioeconomic status and by ethnicity. And we are collaborating with organisations to really try and make sure we hear all of those perspectives and those voices. And we're also extending our work hearing GPs' perspectives on complex care journeys to undertaking qualitative work with people across the whole care journey, so general gynecologists and specialist gynecologists, with the aim of really trying to bring it all together. And the last thing I'd say is that in doing this work, Abi and I have firstly been incredibly grateful, and we've had an amazing time. We feel incredibly lucky to be doing it. But also these projects have given us the opportunity to meet just such fantastic people with whom we continue to collaborate. We're working to develop an international network of primary care researchers in endometriosis and all of that has happened because of our original support. Thank you, I think is what I'm saying.
Oh, well, thank you. There's a very nice comment in the chat, which I hope you get to read. It's not a question, but and another amazing example of fantastic project couldn't be done by anybody else other than people working in with a knowledge of primary care. No hospital consultant's going to be. It's how many women are affected by it. It's a fantastic work, which has also led to your own development, and you're getting a prestigious NIHR doctorate, and I'm sure it's supported your career enormously as well, Abi, with all those grants and things. So fantastic. I'm just thrilled. And really, as a woman, really important work. Have we got any questions? Otherwise, I'll ask a question.
Not at the moment. I think someone did put their hand up. If that person wanted to then pop their question in the chat, that would.
Please do. If you've got a question, do put them in the chat. But in the meantime, I was going to ask, I was very interested. So you developed vignettes or scenarios, used them to stimulate qualitative interviews, and then brought the findings of the qualitative interviews back to patients to develop your top tips. I thought it was a really lovely circular methodology. And did you develop, was it your invention, or how did that come to you?
Using vignettes was something that Professor Ziebland in our research group, who I think has supported and mentored both Abi and I before, and I have used it. I have used it in a previous study. In fact, I used it in the qualitative study I did in my in practice fellowship, which was my very first foray into research, and it worked. And it worked as a sort of almost a neutral kind of step out, think aloud, because what we were trying to was considerations, and we were really mindful, trying to not make it a test of knowledge or a test of practice or an appraisal of what they did, but a space to think about the sort of things they think about and things that people might wonder about and how they might navigate their local structures. So I mean, it doesn't work for every study, but it felt like it worked really well for this one. We allowed people to add bits to reflect on cases of their own if they want to, and many people did, but they didn't have to. We had a kind of extending vignette, so we responded and we added, we let people change the vignette. So people might say, well, I've answered your case in this way, but actually what I really always wonder about is this bit. And we captured all of it. So it was very much a starting point that we used flexibly. And we did, I can't remember if I meant to say it, but we did create the vignette in partnership with people with lived experience. But it was very much just a starting point that we kind of deployed it quite flexibly. About taking what we'd heard about what GPs were saying back to people with lived experience, that just felt like the right thing to do, didn't it, Abi? Because we wanted to make sure it was meaningful for everybody and that we could really use what we'd heard. We didn't set out to do a top 10. It's just that they had so much useful feedback based on it. It felt important to try and capture that in the paper.
Yeah, it seems a really nice. There's the circularity of it and the appropriateness of it just sounds really good. Anybody else got any questions? Well, congratulations. It looks like you've already got some takers and some contacts made from the chat, so that's excellent. Thank you very much indeed, and congratulations on the work. Thank you.
Thank you for the opportunity.
Thank you. And now our final presentation is from Meg Armstrong, who was a colleague of mine and then has defected to UCL, but I'll forgive her. And she's talking about self-management of multiple long-term conditions in people experiencing socioeconomic deprivation and an interest in supporting people experiencing socioeconomic deprivation. Good Lord, it's a very long title, Meg. Perhaps you better give you a title yourself.
I'm not quite sure that was my title. Maybe I sent it over wrong. Right, shall I share my slides, Steph?
Thank you very much.
Oh, right. Am I? Go. You can see that, can you, Steph?
Yes, thank you.
Fantastic. Okay, so the talk I'm giving today is on self-management of multiple long-term conditions in people experiencing social economic deprivation. So multiple long-term conditions are usually defined as 2 or more health conditions that require ongoing management, sometimes referred to as multimorbidity. The prevalence is around 1 in 3 adults living with multiple long-term conditions, and that's rising across the whole of the population. But the prevalence is particularly higher among those experiencing social economic deprivation. So as well as the prevalence being higher, they also tend to have more long-term conditions, so sort of 3, 4, 5, 6 and onwards. They tend to develop them at a younger age, and they tend to report worse severity of health conditions. So when I'm sort of talking around social economic deprivation, there's sort of a range of characteristics that I think contribute to this. So obviously there's the obvious one of finances and maybe living on an inadequate income. But there's also other things to consider, such as perhaps they live in an area of deprivation where there might be a lack of resources, there might be high crime rates, less employment opportunities. They might have grown up in an area where they just wasn't given access to good quality education, or they might be in a job that just doesn't really give them any autonomy, or perhaps they're in a very manual job. So there's all these characteristics that come together that impact this group. So self-management, it's a bit of a mixed bag, but there is evidence that it can help people manage, is associated with improved health outcomes for a range of long-term conditions. And it involves taking a proactive approach to managing those conditions. So usually by adopting sort of healthy behaviours, medication management, and also managing the emotional burden that comes with having all these long-term conditions. But the evidence suggests, despite people experiencing social economic deprivation having more of these conditions and worse severity, they're less likely to self-manage. So my project, that was actually funded by 2 of the SPCR grants, explored how can this population be better supported to manage their multiple long-term conditions. And I did that in a range of ways through systematic reviews of qualitative evidence and systematic reviews of trials. And also we went out and collected some primary qualitative evidence with carers, healthcare professionals and the population themselves. And today, what I want to focus on is the experiences of self-managing multiple long-term conditions from the perspectives of people experiencing social economic deprivation. So I've put some characteristics up there just to give you an idea of sort of the people that took part. There was a total of 28 participants and sort of their circumstances. And then getting straight into the findings, what we found. So unsurprisingly, there were challenges accessing and using health services. And this was predominantly because they viewed the health services as very disjointed. It was quite single condition focused. So they felt that they were attending lots of different appointments for all their different conditions, and there wasn't that holistic management of bringing all their conditions together and how they should be managed combined rather than on an individual level. And someone's put here in a quote, it just feels like there needs to be more of a connection between the health service, other public services and even charities. At times, there was a lack of cultural awareness. There could be miscommunication, a lack of understanding when discussing multiple long-term conditions with healthcare professionals. And this very much come from the participants' perspectives that they were going into these appointments and sometimes coming out feeling more confused than when they went in. There was also a huge health impact on the well-being of navigating the welfare system, what we sort of refer to as benefits, where people were having to complete lots of online forms. They were waiting weeks and weeks to get access to financial services and then being told they weren't entitled to them. They had to apply for something else. And navigating all these systems was really burdensome. We found empowerment and disempowerment through technology. So I think sometimes there is a concern that with digital interventions, we might be leaving certain groups behind. And I think there was some evidence of that here. There was digital exclusion. So this was due to either not having access to, reliable internet, whether it didn't take forever to download a YouTube video, or it could be that they didn't have the latest smartphone that meant that they couldn't have all the latest apps included on them. or there was a lack of skills where they just didn't have, they didn't want really to use smartphones or the internet or things like that. But when people did sort of use technology, it really helps them to self-manage in a range of different ways. And someone's put here, I found modern technology really great because Alexa will tell me when it's time to take your meds. But there was other great examples of people self-educating through the internet, and some people who felt very isolated and couldn't get out very often, also able to join sort of online forums. So there was a range of ways that actually, if we could upskill people and give people access to, you know, the latest technology and the best technology they can, it's really empowering for them. There were many impacts and causes of exclusion to self-management. So unsurprisingly, people with access to support through family and friends self-managed better. However, there were situations where people had access, you know, to support groups around them, but wouldn't necessarily go to them for advice. An example of this was someone had sort of several healthcare letters, and they didn't really feel like they had anyone they could go to that they could discuss it with and could help explain. So they didn't have anyone that maybe worked in the health service, for example. So their social capital was reduced, I would say. There was also feelings of being judged or stigmatised because the health conditions. This was particularly problematic when it comes to their employers. So they were really worried about their employers finding out that they had these health conditions and would try to hide it from them because they thought they might lose their job or be penalised in some way because of having those conditions. So, for example, they wouldn't, if they had a GP appointment or any sort of appointment, healthcare appointment during the day, they wouldn't feel comfortable going to their employer and saying, I need to take time off to attend this appointment. And again, unsurprisingly, there was that area-based and economic exclusions which limited self-management. So someone says here, I know that I feel quite lonely and I'll probably say quite isolated, because can't really do some of the things that a few of my friends can do. I don't feel safe in the evening, so I'm not able to kind of meet up with people. Many of the population were adapting some of the sort of self-management, common self-management strategies that we might use. So they might pursue free or low-cost activities, for example. Some sought out complementary healthcare alongside traditional medicine. And of course, activities needed to be culturally appropriate. So there was one example I can think of where a Muslim woman who was offered free swimming classes, but didn't want to go because she was concerned it might be mixed gender and didn't feel confident about asking for clarification around that. But here's a nice example of someone who found a local service that was really helpful for them. So they said they have a local diabetes group in the local church, and I go there and we're quite lucky because actually they do give you food that you can eat while you're there, and sometimes I manage to have something to eat. So now lastly, coming on to what's the impact of this project. So across all of the different, there's the sort of the obvious academic dissemination. So from this project, there's been around 7 publications. One is in draft at the moment, which will be a recommendations paper, and it synthesises all of this qualitative work, the systematic reviews. And this has been presented to a workshop of experts for, you know, so people with the conditions, their carers, healthcare professionals, charity workers, commissioners, who have all come together to refine these recommendations. And they range from sort of, you know, policy level, you know, people shouldn't be managing their COPD in sort of damped and cramped housing conditions, but also things that we can do now on the ground in clinical practice and as academics. I've presented these findings at numerous conferences. This paper in particular was picked up by the NIHR evidence synthesis of multiple long-term conditions and inequality, addressing the challenges. So that was really great because it discussed social economic deprivation, but it also sort of highlighted that this group is really diverse, so you need to take an intersectional approach to it. I also applied for some smaller spin-off grants to develop infographics, co-produced a video with this population, and I also wrote a reflections paper, which was really about how all of this was all about how do we involve this population in research meaningfully. And my reflections paper was really about all the learnings that I've had, things that I would do differently, things that I wish were available and aren't, and things that, you know, going forward, I would really recommend for people who are trying to sort of meaningfully involve this group, either as participants or as PPI or as co-producers, etc. Of course, awaiting outcomes for next steps funding. I'll certainly be looking to take this research further, because I think what this project's done is really emphasise there is a problem, it's getting worse, but there are practical things that we can be doing. It's been fantastic in capacity building. So part of this project, we've recruited 2 research assistants. One now is undertaking a postdoc fellowship. One's now undertaking a pre-doc fellowship. We've also had a PhD student who joined in October, who's looking at multiple long-term conditions, but for people with dementia. Because around 80% of people with dementia are managing other long-term conditions, and we need to consider how they are managed alongside dementia. Whenever I can, when I present this work, I do try to advocate for more representation of academics from non-traditional academic backgrounds. So, you know, people who maybe grew up with parents who weren't in professional occupations, maybe they're the first generation to go to university, but, you know, letting students know that, you know, PhDs are for them. This is how you do a PhD, and these are the career opportunities for you, and that actually your experiences are really valuable. And lastly, I think we've developed like a really great expert community. So as part of this project, there was 2 PPI members who were so invaluable and have been involved in all the stages, and will be involved in ongoing projects. But we've also now got another 15 other PPI members who wanted to join this project. Some who said they've never been involved in research before, or some who have gone along to sort of PPI meetings, but didn't feel particularly comfortable for whatever reason. So it's really great that we've got that community. It's a collaboration across UCL, Queen Mary and Keele, which has been really valuable for sort of my perspectives as well in my career development, and I've got fantastic academics who are part of this project that have really supported me in leading this project. And then we've also got a group of the experts that I said that I presented the workshop to, who, have given up their time to really try and refine these recommendations to push that we do need to take this forward, that it is a problem. So I think overall I just feel really motivated now that time is now to address this in a meaningful way. I think I'll leave it there. Thank you.
Well, thank you very much, Meg. That's wonderful. And another example of somebody who has leveraged from some smaller projects, more and more work, and built a whole body of work. There are a couple of questions in the chat. I don't know if you want to read them out, Jess.
I can do. So Martin has asked, did you look at all at unpaid carers looking after relatives with multiple conditions?
Yeah, so one of my other qualitative studies was exactly that. We did explore carers, and we have got some sort of findings from that. So these carers are also living in social economic deprivation. Obviously, we know that unpaid carers in general, just they're so valuable, but yet really sort of experience adversity. And then there was this other layer of complexity of the carers trying to care for people, but often many of them had their own long-term conditions as well. So there was the managing their own health, almost prioritizing and burning out through trying to look out for their family members and their loved ones. And I think there's definitely some work that needs to be done about how we can support that group better.
Thank you. And I think
somebody's just asked for a link to your reflections paper, Megan, and I don't know whether that's something we can pop in the chat.
Yeah, absolutely. I can. I'll have a little look and pop it in the
Brilliant. And then Kirsty has asked, I'd love to know more about what you feel has made so many PPI members feel like they want to be involved. I'm guessing it is relationship building based. That wide range of representation is so important and is fantastic.
Yeah, I think. Yeah, I think because I started with 2 fantastic PPI members who are really who represent this population so well, and they do everything alongside me, and they've been really helpful at building up these relationships with other PPI members. But I think as well, not all, but sometimes trying to become a PPI member might involve sending a CV or a personal statement, and a lot of this group don't really some of these groups don't have CVs because that just wouldn't be appropriate for their jobs. You know, we're flexible in the ways we meet. I try to keep it as informal as possible, and less academic as possible, and really just try and listen to their experiences because they're so valuable. So I think that has just worked really well. And I think because we've got a lot of people who have joined who have not been involved in research, they haven't got the sort of the polished, they felt that maybe their word said that they felt that they were a bit unpolished compared to other PPI members. But yeah, definitely relationship building.
Thank you. And then just from Amanda, who would love to be part of any work for carers. She just wanted to put that out there. So
yeah,
but we've
fantastic.
got Amanda's details for anything you're doing in the future.
Oh,
Meg,
excellent. Yeah.
I just, whilst we wait and see if there's any last questions, I just, Meg, I was just going to, I wondered if I could ask a question. I was interested in you saying that some of the interviews people had said that they found online fora helpful, and that's an area of research at Queen Mary where we're actually trying to exploit online fora to support people. And I wondered if you got any more detail on that. With my ears pricked up hearing about online fora being useful for people.
In terms of sort of reducing social
management. Yeah, I don't know. You said that you were using as an example saying the digital world have really helped some people, and one of the examples was online fora.
Yeah, I think that's been incredibly valuable for some. One, because they meet people in similar situations to themselves, and that's a lot easier if you can go, you know, you can access people from the UK or through worldwide even, you know, you can interact with these people that online in an online way, and you can reach more people. So that's, I think, sharing experiences. There was definitely something around, I think, valuing what other people in their situation have to say and taking on board their advice and what they've done to help manage. Some people really enjoyed it because they would sort of take on like a motivational role in the groups. But also we had a few people who were quite self-isolated and didn't go out very often at all, either due to their health conditions or because they didn't feel particularly safe. So it really helped them have a sense of community and belonging that they just wouldn't have. So I think they are incredibly valuable. There are, of course, caveats to that, you know, and they've got to be managed in the right way. But yeah, I think they're a really positive way to self-manage for this group.
Thank you. I can't see any more questions. So I think we're about drawing to the end. I'd just like to thank all the speakers today. I think it's been a fantastic session, fantastic speakers, and also a fantastic advertisement for the School for Primary Care Research and the work it does. So I'm delighted to hear all your things, and I'm sure the audience all would like to thank you very much as well. So thank you.